Hello, everyone. I'm Nitin Jain from the Department of Leukemia at MD Anderson Cancer Center in Houston, and here representing for CLL Society. And along with me is my colleague here, actually in the Department of Leukemia, Dr. Bill Wierda, who I'm going to ask to introduce himself.
Hi, I'm Wierda from MD Anderson. I'm in the leukemia department and work in the CLL program.
So we're going to discuss an abstract which was presented at ASH, where Dr. Wierda is the lead PI. So this is an abstract. So CAR T-cell therapy are approved for patients with CLL, namely with a product called Liso-cel or lisocabtagene. And that the new abstract, which was presented at the ASH meeting, was giving the patients CAR T-cell therapy, but also combining it with Ibrutinib. So I will ask Dr. Wierda to maybe summarize us what exactly was done and what were the results compared to maybe just CAR T itself.
Sure. So the Liso-cel is the CD19 CAR T product that, as you said, is approved for patients with CLL. It's approved as monotherapy currently. There was work done at the UPenn by the UPenn group originally that looked at the product that was generated in patients who had been on Ibrutinib when they had their T cells harvested, and they compared that to historic product that had been generated from patients who weren't on any Ibrutinib when they had their T cell collection. And what they found was that there was a more potent product made when the T cells were collected when patients were on a BTK inhibitor, suggesting that there is some alteration in the T cell function and T cell exhaustion or reversal of T cell exhaustion when patients go on Ibrutinib. And so based on that observation, and also the trial data that had been developed by that group as well as the Seattle group, where they showed that perhaps the side effect and toxicity profile was less when patients were treated with CD19 CAR T cell product while they were on a BTK inhibitor, and there may be a more effective result with the combination. So there was a cohort on the Transcend CLL 004 trial that was a combination of Ibrutinib plus Liso-cel, where patients who were relapsed and refractory, if they were not on Ibrutinib, they were put on Ibrutinib. If they were already on Ibrutinib, they would continue, they did continue their Ibrutinib, and there was T cell collection. Product was made at the production facility. Patients remained on Ibrutinib, and then when the product was available, they were treated with a Liso-cel combined with Ibrutinib, and they could remain on Ibrutinib for an additional 90 days after infusion. And so that cohort consisted of 51 patients who were all previously treated. All of them had had a prior BTK inhibitor. Some of them were refractory to BTK inhibitors. About half of them were refractory to BCL2 based therapy also. And with that combination cohort, we presented the efficacy as well as the side effect and toxicity profile. The complete remission rate was 45%, and the overall response rate was 86% in that combo cohort. Now that's higher than we reported for Liso-cel monotherapy in the relapsed refractory population on the Transcend 004 trial. Almost 90% of the patients were MRD undetectable in blood and bone marrow at response assessment, and their responses were durable. The median overall progression-free survival was 31 months. And so these patients have done very well. They weren't all the so-called double refractory population. And the side effect and toxicity profile was similar to what we reported for Liso-cel monotherapy in terms of the CRS and the neurotoxicity rate. So overall, the combination was active. We're doing analyses now to compare with the monotherapy cohort to understand if it is more effective based on the patient characteristics, and we'll be reporting that at subsequent meetings.
All right, great. So I think maybe from our patients who are listening here, just to kind of, so the MRD is minimal residual disease, which is like a low level of disease detectable. It can be checked in the blood and the bone marrow. So maybe to clarify, I think you said the MRD rates were pretty high, and they were in the blood or the bone marrow, and what was it compared to when the CAR T was given just by itself in a previous study?
Yeah, so both of those are high rates of MRD undetectable. So about 90% in blood and bone marrow on the combination cohort. It was similarly high for the monotherapy.
Got it.
My impression has been that this product works very well at clearing disease from the blood and the bone marrow. The challenges can be more the nodal disease. And for that reason, I like the concept of adding it to a BTK inhibitor, because the BTK inhibitor, as you know, that compound or that category of drugs works relatively well at shrinking nodal disease.
Right. And maybe some patients may be thinking that the work which was done is with Ibrutinib, but can that be extrapolated to second generation BTK inhibitor or non-covalent BTK inhibitor, or what kind of, I guess trials are being planned, or what you're maybe thinking about that?
So with Liso-cel, there's not, as far as I know, there's not more trials planned or ongoing with combination with second generation BTK inhibitors or non-covalent BTK inhibitors. My thought is that they're probably similarly effective in combination, but there's not direct data to substantiate that. So perhaps at some time there will be, but we don't have data, and not in the foreseeable future will there be a large cohort of patients treated with the second generations post Liso-cel.
All right, thank you very much, Dr. Wierda, for your nice summary of this important abstract from ASH. Thank you.
Thank you.